I would request Dr. Ajit Kumar, Dr. Sachin Shah, Dr. Shikha Gupta, and Dr. Kash Bhatta to please come forward and take your seats. Thank you.
Good evening and very warm greetings from the panel. Uh, it's again an interesting topic because in cardiac arrest, how soon you establish the return of systemic circulation without any neurological deficit, that is the aim. So these scenarios first will be discussed by Dr. Krishna Mohan Gula. He is from AIMS Bhubaneswar, and his interest is renal replacement therapy, bronchoscopy, and infection control. He has many publications. So he is going to discuss with us Asian scenario, ECPR Asian scenario. Please.
Thank you, sir. Thank you for the introduction for this special non-technical talk. So, my outline of the topic would be because we doctors are less knowledgeable in geography, and so that I would tell something about the Asian continent, ECPR definition, what are the ECPR data as per the ELSO, and ECPR data in India, and what are the hurdles we are facing for ECPRs and the way forward. So if you look at the Asia map, it has total 6 regions. It is North Asia Peninsula, Serbia, Far East Asia, that is most developed part of Asia, that is China, Japan, Korea, and Taiwan. And Southeast Asia, you have Thailand, Singapore, Philippines, Myanmar, and Vietnam. And we are in South Asia, India, Pakistan, Sri Lanka, Afghanistan, Nepal, and Bhutan. And West Asia, you have Bahrain, Iraq, UAE, Saudi Arabia, Turkey also. And Central Asia, you have Kazakhstan, Uzbekistan. So, if you look at the publications of on ECMO, all the 6 parts of Asia are there contributing to the ECMO publications in the literature. So, if you look at Asian population and the economy, Asia considers around 60% of the world population, around 50 nations, and it has the largest continent economy compared to other continents in the world, both in the GDP and the PPP. What is the GDP? PPP is the buying capacity of an organization and selling capacity of an organization. So both are very good in Asian continent. And majority of these economies are by Japan, China, India, South Korea, and Indonesia. So with this type of population and the economy, I think that there are people who require ECPR, and we need to work out more into this technique so as to save more lives, because we are almost 60% of the world population. If you look at this Asian health chapters, there is 2 chapters are there, Asia Pacific and SWAC also. Asia Pacific, Australia, New Zealand, China, Hong Kong, Indonesia, Japan, Malaysia, South Korea, Taiwan, and Thailand. And SWAC also we have South Asia, the West Asia, Africa, and Central Asia. We comment this SWAC also. So if you look at the data of SWAC also in 2021, there are around 28 cities in SWAC region. They are conducting ECMOs, and with consisting of 45 centers. But there are around 16 centers, 16 countries in Asia that come under the SWAC group. They are not doing ECMOs at all. So this is about the brief geographical data of Asia, where the ECMO being done. And if you look at the small definition, what is the definition of ECPR? It is a rapid initiation of VA ECMO during conventional CPR in patients who experience a sudden and an unexpected pulseless condition, the secondary to cessation of cardiac mechanical activity. And the aim is to provide adequate perfusion to end organs when the potentially reversible conditions were being managed. In the most common for the adults is the coronary artery disease. So if you look at the ECPR data, if is the ECPRs in the neonatal age group, pediatric age group, adult age group. So this is the data as per the 5th March 2023. So if you look at this Asia Pacific and SWAC also, and in the neonatal age group, around 211 ECPRs were being done in Asia Pacific region, and 37 in the SWAC also, and 591 in Asia Pacific in pediatric ECPRs, and 100 from the SWAC also, and around 2,700 odd patients, adults received ECPR in Asia Pacific, and in the SWAC around 305. But you know that so all this all the data we are having are not being reported to SPAC also. So this may be underestimation of what we are having. So if you look at the evidence on ECPR contributed by the Asian countries, so I have digged into few literature. It is one of the recent published scoping review in 2021. So they looked at around 60 observation studies out of around 3,600 odd patients. There are 34 studies on OHCA and 6 on IHCA, and then 22 studies on OHCA and IHCA. So out of these studies, around almost 23 studies and more than half of the patients are from Asian continent, that is from Japan, Taiwan, Singapore, and Republic of Korea. And European countries contributed on 28 studies, and Canada, Australia, US contributed on 12 studies. So around 23% of these patients had term survival, and around 18% of these had good neurological outcome. If you look at the systematic meta-analysis, and they looked at patient who had OHCA underwent the ECPRs. So they looked at about 80 years. They looked at 6 studies. They look at the survival and good neurological outcome. If you look at these 3 studies are from Asia itself. And again, if you look at the ECPR in children, there is a recent meta-analysis published in 2022 September that included around 30 studies, around 3,800 odd children were included who received CPR over 10 years. So the pooled survival to hospital discharge around 44%. So almost in pediatric population compared to the adult population, the majority of the data is on, most of the data is on IHCA as compared to OHCA. And if you look at the contribution from the Asia, around 9 out of 30 studies are from Asia, around 50% of the patients are from Asia. So if this is about the Asia contribution to ECPRs, but if you look at the India, where it is the evidence from Indian studies, it is predominantly restricted to the social media and from newspapers or WhatsApp. So this is one of the study, one child in the Rala hospital survived by doing ECPR in 2022 January. And one more 4-month-old kid, who is a case of post-op case of Al-Kappa, that is anomalous left coronary artery and pulmonary artery. He had the post-operative period had cardiac arrest, and then he survived. ECPR was given to the baby, and he survived. And one more for 38-year-old gentleman, he received ECPR in Chennai for his hospital, and he survived. So this is the middle times where these ECPR success stories are being highlighted in the social media rather than to the reported organization. And as it is one of the one study I found that published in 2021. It is from Chennai group from Apollo Chennai. So in the year 20 in the 10 years in 2011. They did around 186 ECMOs. Out of 186, 11 were ECPRs, and all were in hearts for cardiac arrest. So the 6 could be separated from the ECMO, and 5 were discharged home, and their downtime for ECPR around 35 to 85 minutes. So these are the in the cohort of patients who received ECPRs, predominantly drug poisoning and post-coronary angioplasty, and some few patients with pneumonia and cardiac arrest and IL with myocarditis. This is the official data that I could find from India regarding this ECPR. So we did a ECPR practices website in 2019 before the COVID-19. So there were 63 participants were there. Around out of the 63 participants, they told that 6 performed ECPRs. The median ECPRs are around 2 ECPRs per year, and the cost per ECPR, it is a minimum of 2.5 lakhs, and 57 out of 63 told that they don't do ECPRs because of lack of experience, lack of equipment, and financial issues. So we have given the same questionnaire to the participants after COVID, where the awareness among the health professionals increased regarding ECMO. We are still doing the study. There were 54 participants responded, and out of 14 out of 50, that is 25%, they told that they perform ECPRs, around 3 ECPRs per year, and around 36. So if you look at this, the data in 2019, 2023 now, So that around 6 centers in India, six metropolitan cities in India were conducting ECPRs. Now it is increased to 9. Even though there is not no much greater increment in the cities wise, but the number of centers in each city that are doing ECPRs has increased definitely in last 3 years, especially after COVID-19. So this one, the data I brought out from Dr. Pranay Oza, and this recently he did a survey of 81 participants, and they told that in his survey, around 43% perform ECPRs, and 29 told that they did around 5 cases in last 1 year, and 5 told they did around 5 to 10 ECPRs in last 1 year, and one told that they did more than 10 ECPRs in last 1 year. That means that definitely the number of ECPRs is definitely increasing in India. So if you look at what are the components of ECPR that we need to look at for its success, if I divided 3 components, that is one is before ECPR and for ECPR and after ECPR. Before ECPR, for out of OLCA, there should be early recognition of cardiac arrest or pulseless arrest, whatever it may be. And the public awareness of CPR is very, very important, because for an effective ECPR to be successful, the conventional CPR should be very strong. And the conventional CPR should be very optimum and high quality CPR. That's why we are more the programs on ALS and BLS we conduct all over the country, and the transport should be optimum. So if you want to do a good OSA program, so transport facility should be very good. And for ILCA, it is again the same recognition, because many of the patients are in the ICU. Recognition may not be a problem, and all healthcare staff training should be there for both medical, non-medical professionals for effective CPR and optimum conventional CPR, and optimum inter-hospital transport facilities is also very important. And moreover, that also admission commitment for ECPR is also very important. And if you look at for ECPR, you need the machine, the cannula, primary circuit, ready to go manpower to do the ECPR. Whenever you call, they should reach within 5-10 minutes. And there should be a skillful specialist who can do cannulation when the CPR is going on, and the trained ED physician, resident intensivist who can take care of the process of ECPR. And if you're hybrid cath lab, it is very important, so that if after putting an ECPR, take the patient to the cath lab and do the angio, and take whether you can do angioplasty or bypass, coronary angiogram bypass based on the patient's requirement. And after surgery, and we need to look at the etiology as early as possible. So if you look at in our scenario, all these things can be modifiable factors, but these some things that we are still struggling on. So for OHCA, what I say, we are still struggling for early recognition. You might have seen in our routine daily life, and public awareness is not very much. Optimal conventional CPR, high quality CPR is not very much very good in bystander CPR, and optimal transfer facility is one of these 3 things where we have to work upon to improve these outcomes in OHCA. So what are the hurdles in our scenario? As Dr. Sunil Kubin has already told, the finance is a major one that we are struggling day in and day out. The trained manpower, yes, there is also, because of the increment in the training overseas, and the fellowships in India is increased dramatically over last 10 years or so. That is, so the trained manpower is increasing gradually, and the awareness among the peripheral healthcare providers needs to be improved. And again, the public awareness for high quality CPR is again we are struggling with, and the optimum transfer facilities we are struggling with. So what we can do to improve the ECPR in our scenario, or to make it practicable, the first we need to instill the passion in the young intensivists regarding the extracorporeal life support, and improve the transport facilities. And if a patient comes in the ECPR in cardiac arrest, still you know that one way to reduce the financial burden on the family or the hospital, you can keep the conventional CPU machines primed and keep in the emergency if it is possible, so that if the patient comes, you can put him as early as possible in the conventional CPB, or till you get the time you can put on a CPB oxygenator, which is less costly compared to the routine ECMO oxygenators. So if you till you take a decision whether to go for ECMO, or till the family takes a decision to go ahead, or the underlying condition you could diagnose what are the reasons for the cardiac arrest. Till that time, you can go with conventional CPB machine or by conventional oxygenators, so that you can buy some time at a reduced cost. And government hospitals and INIs are the fertile grounds, I say, for to make this technology reach to the people. And the health schemes in certain states are covering ECMO. And I feel that a majority of government funded schemes needs to cover ECMO in the insurance. Just in the end, I would say that yes, we have the patients in Asia, and we are good population in Asia, and we have knowledge, we have technology that is gradually being increasing in the Asian continent, so that is practicable. Provided the only hurdles we are having finance, that I think that will be gradually recovered. Thank you very much.
Thank you, Dr. Thank you for the nice question.
Runs, and he's been an ECMO team coordinator at General University Hospital in Prague. So Jan is going to talk about ECPR outcomes and what does the RCT talk about, or RCT says. Off to you, Jan.
Hello, Bob Roker, and I'm going to tell you a bit about the possibility of portable ECMO or wearable ECMO.
When it comes to ECPR, I know it is kind of impossible in Indian scenario. When we think of out of hospital cardiac arrest and thinking of ECPR, at this point of time, I don't think we can. The only patients come when we can think of ECPR is in hospital cardiac arrest, and that has to be where we know, like it has to be reversible. Maybe acute pulmonary embolism or MI only we can think of. Maybe in cath lab somebody having a cardiac arrest and we have the facilities available there, we can do. Not like somewhere in the ward, it is impossible again. Now the question is, let's say we are thinking of eCPR. Practically, what are the things we need to think about? Shall we keep the one circuit ready? And we need to have, I believe, a mechanical CPR device in place instead of 3 or 4 people rotating among the patient and they are doing CPR. There is impossible. There is no space to do cannulate those cases. So, is there any practical? Because I don't have practical exposure when it comes to eCPR. If somebody can guide me, how we can go forward stepwise when it comes to eCPR.
Let me answer that question and I'll come back to you. So, doing eCPR, there is a lot of logistics involved. You need to know your healthcare system first. Secondly, you need to know the geography which you are trying to cover, and also the transport. Now, you're absolutely right that when you start doing an eCPR program, I think the availability of the resources, you first start in hospital, so you sort of cover those patients with in-hospital cardiac arrest, and then try and expand your wings. So if I give you an example of what we do at Barts in London, and we offer eCPR only during the working hours in hospital. So say if a hospital, even if it is 5 miles down the road, calls me for a patient who's already in cardiac arrest with ongoing CPR, we will not be able to mobilize in time in order to be able to reach to that patient within the first sort of 60 minutes since they've arrested, where the outcomes are considered to be best, that you go on establish circulation within 60 minutes. So we offer that service only within the hospital, within normal working hours. Secondly, in terms of personnel, it depends on what experience you've got. So currently our team consists of only 3 people. So there is one intensivist who is an ECMO cannulator, there is a perfusionist, and then there is either an ECMO fellow or an extra perfusionist who come out. So there are only 3 people who are involved in actual cannulation. In terms of mechanical devices, yes, we do kind of encourage people to put on a mechanical device, whether they are en route in transit from periphery into the hospital, because that takes away a lot of manpower. And also you can get help from those people who are not doing CPR at that time. Thirdly, what you should keep ready. As I said, obviously a prime circuit is always helpful. what we've done is that we've done a lot of simulation mimicking the ECPR. And in real time, like say if I'm sitting in a coffee room and suddenly my bleep goes off, I won't know that I'm the part of that simulation team, and we sort of actually time the response, how much long it takes me from getting out of that coffee room into the cath lab or say into an intensive care, and activate the ECPR team, and then how long it takes from that to cannulate the patient. So that needs a lot of simulation in order to achieve that kind of timing and stuff. And lastly, we are running a trial at the moment, which is called a sub 30 trial, where we are looking into the logistics and feasibility of offering CPR on the street. We've got 5 patients, we're looking for one more patient, and then we'll be able to publish our data, and logistically and financially, whether it's viable of running CPR and putting patients on ECMO on the street.
Make this back.
There's a talk.
That's it.
There's a talk. Just 2 minutes. I don't have anything to disclose. It's long back 2015. Our experience of ECMO was in 3 cases. Just so it was just a 3 months old ECMO program, and it was morning 11:28 when we got a code blue call from cath CCU. A patient was shifted from cath lab, and just few minutes back, and patient was in the cath CCU, and we got a code blue call. I was on duty, and I reached along with the ACLS team, where CPR was in progress. So as a team leader, I took to her, and we continued with the ACLS. So far, they had given 1 shot. Quickly asked a brief history from them that what has been. So he was just a 60-year-old, 80-year-old male patient who admitted a day back and was diagnosed as a ACS. Patient was stable throughout the course. ECG and lab reports were unremarkable, and he was just undergone the coronary angiography. And angiography had shown an ostial left main disease with a triple vessel disease. Patient was shifted to the coronary care unit, and family was being discussed of urgent CABG. And suddenly the patient had a cardiac arrest, and we were in the picture. Initial rhythm was ventricular fibrillation. So multiple shocks, adrenaline, amiodarone, high quality CPR, but it was a tight ostial left main. So no response, we were continuing. And this was the time when I discussed with my cardiologist. So you can just imagine, 3-month-old program and 3 experience of 3 cases. So I talked to the surgeon, yes, no for next few minutes, and talked about the ECMO support. So what next to be done? I said we have to either take him to the surgery or we have to take him for PTCA, emergent PTCA. So finally, our cardiologist agreed to take chance, and we talked to the family. Within 19 minutes, this was 19 minutes when we started talking to the family, and we were fortunate enough to get a consent from the family that go ahead for that. So quickly, our ECMO team was activated, and patient simultaneously CPR was in progress, and patient was intubated down and was shifted to the ECMO room. So we initiated with a quick VA ECMO percutaneous. Right femoral artery already sheath was in, so we were quickly able to achieve the arterial cannulation, and we were fortunate to do a percutaneous venous cannulation as well with the ongoing CPR. So we started with the ECMO within few minutes, and we stopped the CPR, increased the ECMO flow to 2.6 liter. Now this fine BF was converted to the force BF. It means probably some perfusion has been established. We maintained the mean pressure on 60 with the support of epinephrine and norepinephrine, continued the mechanical ventilation. And now it was a quick discussion among the cardiac surgeon, cardiologist, and us that what to do. Surgeon said no, yes, the Gauthil status not known, almost 25 minutes of CPR, more than 25 minutes. ABG was showing severe metabolic acidosis and lactic acidosis. A partial correction was done. We put a central line, and finally cardiologist decided, okay, we'll take him for PTC. So with 3 cases of experience, we shifted this patient from the ECMO room to the cath lab. Rhythm was still ventricular fibrillation. So finally, the lead was taken by a cardiologist. Fixed wrench catheter was placed. They did a balloon dilatation to the left vein, to the left anterior and left circumflex artery, and they placed the long stent to this and achieved a TB3 flow. And the moment they did it, We gave a 200 joule shock and now it converted to the EU ventricular rhythm, white complexes, but pretty organized. His blood pressure started showing a good ejection of 82 by 38. Blood gases showed a bit improvement. Patient was shifted back to the ECMO room. And this was the post shot was taken after this OBA. We did, and after that they had placed a stent. This was the pre-angiography. So finally we continued with the VE ECMO. After some time, this rhythm started showing towards the sinus rhythm, narrow complexes. Patient hemodynamics started improving. And we did an echo. At that time, it was just 30% EF with the regional wall motion abnormality. The inotropes were coming down. He was maintaining his good blood pressure. Then gradually blood pressure started improving and echo showed a ejection fraction of 40. But X-ray was really bad. We were able to, it was difficult to maintain the saturation because of his fluid shift in the lung, pulmonary edema. Lactate were also coming down. So finally we decided, because the patient had a good ejection fraction, so we switched VV ECMO to the VV ECMO by placing a 17 French cannula to the right internal jugular. And femoral arterial cannula was removed, and gradually patient became stable. Though in the due course he developed the upper GI bleed. Next morning his VV ECMO was also stopped because X-ray was almost clear. And next 72 hours he was off ventilator. Hospital course was uneventful and he was discharged on day 8 from the hospital. So benefit ECMO, what it does, prompt restoration of the circulation. It allows us to do an investigation as well as some interventions, and definitely we can give therapeutic hypothermia to protect brain. Maintains peripheral perfusion to make the patient organ donor in case patient is not recovering. So, but we should always remember not that every patient can be a candidate. First, we have to look at the reversibility. In our case, yes, it was reversibility because we knew it's osteal left main disease. Initial rhythm was VT and VF, it was a witnessed arrest. No flow was much lower because our staff reacted quickly and CPR was started very quickly. And there was no situation when we were not able to maintain adequate perfusion pressure. Contraindication, we found that there was no contraindication per se in this particular case, so we have to be very careful for it. Important, high quality CPR has to be continued. Quick evaluation and look for eligibility of the ECMO. Activation of team, coordination of team, talking to the family and doing a counseling and consent. And the most important thing is a checklist that we are not missing anything. Though, honestly, I'll say at that time we were not organized, but we did it. But later we learned that yes, we should have an ECMO crash cart ready, we should have all consumables in one cart, but along with that one checklist, so that we are not missing any step throughout the course of, especially during the emergency situation. So to conclude, it is possible, it can be done. Any one of us can do. The only thing we need, I intend to do it. A teamwork required, CPR team, ECMO team, they should work in coordination. High quality CPR is the crux of success. Good communication amongst a team member as well as with the family, and the time is most crucial. When it has to be done, this has to be decided very quickly. Thank you very much. If any comment or questions required. No question? Thank you.
I think what I'll say is a great effort, and it was always a pleasure to work with you. And I feel honored that for long I've worked in a ECMO team led by Dr. Ubay. Thank you, Ubay.
Thank you so much.
He's a consultant in Doha, Qatar, and his area of interest is transportation on ECMO simulation and critical care after surgery.
The voice quality is okay and you can hear me clearly. Very much for the organizing committee for allowing me the opportunity to be a part of this, and my apologies for not being able to join the esteemed faculty and the group and the conference because of some issues with my visa. So my talk and the title that was given to me is about the ACDR early phase management challenges. So I would like to share my screen with you. I have no conflict of interest with regards to this topic, and we would like to go through some of the challenges.
Recording in progress.
after commencing your ACPR. So to start with, we need to understand a little bit about the physiology and pathophysiology of cardiogenic shock or myocardial stunning or whatever happened to the heart after a cardiac arrest. Basically, you have a very poorly contractile heart. And to understand this better, you look at the pressure volume loops of the heart, and as you can see here, the red dotted line is the normal line, and the blue line with the downward and rightward shift is the bad line. This trapezoid shaped area there, that's your cardiac cycle, and it's basically the 4 phases of isovolumetric contraction, ejection, relaxation, and filling. 2 important features of this diagram: the width of this line represents your stroke volume, and the height represents the systolic blood pressure. This line, the end systolic pressure volume relationship, is quite important because, as you know, contractility could be preload and afterload dependent. And by looking at this ASPVR, we understand or we recognize the contractility out of the context of preload or afterload. So it's an independent representation of the myocardial contractility, and that's quite important. And the slope of the line is here, and the intersection with the baseline is there. So if you have a good heart, this ASPVR will move to the left, and if you have a poor heart, it will go down and right. The end diastolic pressure volume relationship, on the other hand, represents what happened at the end of diastole. And as you can see, when you have a poor heart, it's also shifted downward and to the right, and your end diastolic volume is here starting at almost 180, when in fact it should be a little bit at 60 to 70. So this is important to understand. You can have 2 forms of cardiogenic shock or deterioration after a cardiac arrest. Maybe you can have more than 2, but the 2 most common examples I have had here is on the left-hand side with the red is the normal heart in gray and the acute cardiogenic shock. So this happened after you put your Ecpr lines and you are going to the cath lab, for example, and you have a patient still in cardiogenic shock, as my colleague just demonstrated, and you are infusing depressors and imodilators. And this is what happens in this heart. Again, the contractility is poor, the curve or the end diastolic volume is about 120 there. It's not too bad actually. But when you have this in the context of chronic heart failure, you see how different that is. You see how bad the end diastolic volume is. It's about 220, and your filling pressures are much higher. Contractility in both occasions, the red and blue line, are pretty much the same, but the end diastolic volume or the diastolic filling pressures are much higher when you have chronic heart failure compared to an acute cardiogenic shock on a de novo heart. So this is quite important when you start ACVR, because the targets of ACVR are basically you would like to maintain adequate perfusion, and that's global systematic perfusion, brain, heart, kidneys, guts, skin, etc. And importantly, the cerebral perfusion, that's very important to maintain. And you allow time for the myocardium to recover from the insult and the injury. And of course, you would like to avoid any complications associated with the procedure. So, early challenges. What's early? What defines early in this context? It's immediately after your cannulation, you're still in the AD or in the cath lab, and these are the challenges you face, or is it in the first 24 or 48 hours? So the definition of early challenges could vary the way you look at it, or the time you look at it. But generally speaking, you can be faced with any of these or a combination of all of them. The blood pressure is low, the pulse pressure is narrow, you can have both, that's a nightmare. Your lactate is rising, the saturation and the VO2 doesn't improve, you have differential hypoxia or some local complications after cannulation. So all of these can be challenges in the early phase, and we would like to address them. However, the challenge or the problem is it can also be due to any of these or a combination of all of them. So you can have cardiac or lung overload, you can have pulmonary edema or cardiac overload. And in this context, it's your LV that's not adequately offloading, and it's becoming quite distended. And if you have a distended LV that's not filling, clearing the fluid or contracting properly, you have LV stasis and thrombi, and that's quite significant. On top of that, you have hypoperfusion, decreased cardiac output. This could be the reason of the systemic hypoxia, or the pulmonary edema is the reason for the hypoxia, or a combination of both. And if you have some contractility, you have the harlequin or cerebral hypoxia. So this is the pathophysiology of all the challenges I have highlighted here. All these clinical problems could be due to any or a combination of all of these, and it's usually a combination. What does the VA do to your circulation? Basically, the ECMO flow is the arterial blood pressure. So having inserted ECMO, you think the job is done. No, it's not done. The blood pressure is low, so it's a reflex that, okay, let's increase the flow because this will improve the blood pressure. We have a better number, we are happy. However, when you increase your ECMO flow, that doesn't take away all the circulation or the circulatory volume because some of this blood will return to the LV. And then your LV has to contract and generate adequate pressure to open the aortic valve and eject the blood within it. If this doesn't happen, this will be the LV distension. Another source of blood into the LV comes from the pulmonary circulation, the coronary circulation, and any element of aortic regurgitation. So as a clinician, as an ECMO specialist, you have to establish an equilibrium by adjusting your LV EDP, your filling pressure, so that the blood pressure established the arterial is stable and the outflow is very much closer or nearer to the inflow into the LV. And the best indicator, the primary indicator for your left ventricular and diastolic pressures are your pulmonary capillary wedge pressure or your pulmonary artery catheter. So if you are faced with a low blood pressure, the answer is no, don't increase the flow, we'll come to that. You may have to increase the flow, but as you see on the right hand side, the top diagram, what happens here, as we increase the ECMO flow, the width of the shape becomes less till when you have a flow here, about 4.5, 6 liters, then the curve becomes very narrow, the blood pressure is higher, but the ejection is almost nil. And then you have to do something like this, the intervention down below, which I'm going to discuss with you very shortly. On top of that, it's not just about relieving the blood, the LV from the stagnant or returning blood, but when you stretch the LV, that's already fully compliant. What happens that the tension within the walls will become more, and myocardial ischemia will worsen, and the oxygen requirements of the myocardium becomes higher. So you have a very poorly contractile LV, just about to recover from the cardiac arrest. You have done a good job with the reperfusion strategy you have done. However, you are putting a lot of stress and strain on this LV, making it more vulnerable to another episode of ischemia or infarction. So this is the bad VA ECMO for me. It's not usually good, can be bad, but when it's bad, when you increase your ECMO flow to improve the blood pressure, your arterial blood pressure will improve, however, the pulse pressure will decrease. And with progressive decline of the LV stroke volume and shorter duration of the aortic valve opening. This is all because you have increased the ECMO flow and you have gone up on that. Because the lactate is rising, the patient is still hypoxic, the blood pressure is low, whatever happens there. So if you look at your pressure volume diagram again, this will manifest here as this rightward and upward shift. So increase in the ECMO flow from here, you see we have different flows, 1 liter, 2 liter, 3, 4, almost 4, 5 liters there on the red trapezoid shape thing. But you see the stroke volume here at 4.5 liters of ECMO flow is very less compared to 2 liters. If you look at the left-hand side of the diaphragm, this represents your LV volume. So at a flow of, again, 4 liters, your LV and diastolic volume is typically around 150. And that's quite high for the ventricle. The effects of the ECMO on the right-hand side and the left-hand side of the heart are quite different because VA ECMO is quite good for offloading the right ventricle because it removes the blood from the central circulation from the big veins into the ECMO machine, and subsequently your right atrial pressure, your central venous pressure will become low. You see this on the blue part of the diagram there. However, as we say, your aortic pressure will go up and left atrial pressure will also go up. And these two are quite bad together. How we identify LV distension in the early phases of ECPR and application of ECMO. So one thing you can do is to monitor the pulse pressure, and this gives you an indication of the aortic valve opening and closure. You can use your echo in the M mode and gives you a nice picture of the aortic valve. You can measure again the duration of opening and the magnitude of opening. The best indicator for me is a pulmonary artery catheter, pulmonary capillary wedge pressure, and it gives you immediate information about what's happening in the, as a surrogate of the left atrial pressure, right pulmonary capillary pressure. A right radial arterial line is a must. It gives you an indication of the hypoxia. You can monitor your pulse pressure there, and also can alert you early for pulmonary edema. If you use the echo to look at the LV size or dimension, that's not sensitive, especially in the context of a previously dilated LV with poor compliance. And if you rely on chest X-ray, that's totally unreliable. So I would stick to the pulmonary capillary pressure, the pulse pressure, and echo in the M mode to look at the aortic valve. If you have LV distension, the strategies available are summarized in this diagram. So let's go from here. The first one, A. So this is your cardiogenic shock in blue, and when you apply ECMO, you see the arterial blood pressure is high. That's the height of the slope there is higher. It went from the likes of 60 into 90. But however, the stroke volume is less and your end-diastolic volume is low. So what would you do? In B, we applied inotropes. And as you know, that improves your contractility. So subsequently, we went from red to green. The arterial pressure is high. And also there's some improvement in your stroke volume. However, as you see, the LV end-diastolic here is still high. If you use a vasodilator, our typical Meverenone thing, again, this can be good for the stroke volume. However, the arterial blood pressure will typically be dropped. A balloon pump is not much different from your vasodilators or your inotropes. The blood pressure is better, the stroke volume is maintained. However, the scientific solid evidence behind the balloon pump is still lacking. You can do a septal. You can open a septostomy between in the atrial septum, and this can improve a little bit in your blood pressure. However, also the stroke volume. Or you can do a pulse or a graft between the left atrium and the aorta. Again, this is not as good. Other interventions are direct LV venting and applying a peripheral LVAD. You look at them there in this table. Again, the inotropes have the advantage of being simple. We all know how to start some inotropes or some vasodilator. However, the offloading of the LV in both conditions is limited and unreliable. If you put a balloon pump, again, the unloading or the offloading of the LV is unreliable. However, you can put it at the bedside and it improves your coronary perfusion for sure. Balloon septostomy, again at the bedside, and the pros and cons of each is summarized there. There are several options. None of them is perfect choice. All has some pros and cons, and the bedside clinician in the early hours of ECPR is crucial to make an informed decision and decide on the best management strategy. However, we now believe less is more. We have embraced this in ARDS, we have embraced this in CRRT, etc. So I would personally feel that reducing the ECMO flow within limits might be appropriate. You don't have to target a MAP of 65. A MAP of 55 is sometimes appropriate if you have adequate perfusion. A concept of permissive hypoperfusion may arise in future, and we use that. We accept a little bit of a higher lactate, a little bit of less oxygenation, because we don't want to flood the heart with a lot of drugs and medications and interventions. However, remember that insufficient LV unloading is the main cause of poor recovery. So it's a tightrope that we're walking. Hypoxia, as you know, this is a schematic presentation of what your ECMO does, reinfusing the oxygenated blood into the femoral artery, and then you have a watershed area. So hypoxia could be systemic, and this will manifest in your left-hand sided blood gas, or it can be cerebral on the right arterial line blood gas, which has the advantage also, as you see in the diagram, of showing you the pulse pressure waveform and the aortic valve. So a right radial or a right brachial or a right axillary line is a must. And this will help you also to assess where this watershed area between the oxygenated and poorly oxygenated blood is. Is it distal to the subclavians or proximal to them? And this will help you in deciding the best management strategy, because if this is all lungs, you shift to a VAV and you infuse oxygenated blood on the right-hand side here. So you put another return oxygenated blood in the IJ. This goes straight here, and the pulmonary hypoxia as a cause would be corrected. If this is pulmonary edema and LV venting, that will be another issue, and the strategies which we have discussed here are the management strategies. So you need to know what's the reason of hypoxia. Is it lung infection? Is it pneumonia? Is it pulmonary edema? Is it fluid overload? Is it poor LV? So you need to make that decision and treat it accordingly. And we all understand the concept of the north-south syndrome, and I have alluded to that in the previous slide because of the, the watershed area between your native cardiac output of deoxygenated blood and the ECMO blood flow. Finally, I will touch on the cannulation issues and the leg ischemia. We know that leg ischemia happens in about a fifth of patients after ACVR, and the solution to that is a distal perfusion cannula. There are several questions is about when to insert. So in our institution we wait up to 6 hours. So the priority is to establish the ECMO flow. Get your ECMO flow, get your blood pressure, get your circulation established, and then think about your distal perfusion cannula. If you insert a 15 French arterial femoral line, you are less likely to require a distal perfusion cannula, but that doesn't mean you don't need one. You have to closely monitor the leg, apply your pulse oximeter on this leg, temperature probe, or a tissue saturation on this. The size is typically 7 to 8 French, and it's in the superficial femoral artery, and you apply your monitors there. So with this, I finish my brief presentation. I hope it meets the requirements of this very important topic, because having inserted the ECMOs and the cannulas and the reperfusion is not the end of the story. There is still too many important things to consider. I thank you very much for your attention, and I look forward to seeing all of you next time, inshallah. Thank you.
Thank you, Dr. Ahmed.
If that is okay, we move on. I think Jan.
Yeah, absolutely fine.
Jan's
Thank
back
you.
online. So Jan Bolovic, he is a well-known personality. He's been president of steering committee of EuroALSO from 2019 onwards up until last year. He organized a EuroALSO conference in Prague in 2018. And he's been a primary investigator in several research programs, and he's the ECMO team coordinator at University Hospital in Prague. So I hand over to Jan to talk about ECPR and the various outcomes and randomized control trials.
Ladies and gentlemen, it's my great pleasure and honor to be with you today, and my task is to talk about ECPR outcome. What the RCT say. So I'm going to talk about randomized controlled trials in extracorporeal cardiopulmonary resuscitation. This is my disclosures. Extracorporeal CPR states for continuation in CPR using mechanical circulatory support. We use usually VA ECMO in a typical setting, so the vein being the cannula implanted into the inferior vena cava, pump and the oxygenator back to the arterial line. You can see the pictures on the right-hand side, patient at the ICU after the ECPR. ECPR, per definition, is a time-dependent activity, meaning that patients and their outcome relies completely on time of CPR, on time of hypoxia, and also on the way how the organism after prolonged hypoxia is reperfused. In this trial, you see that with increasing time here over 15 minutes, the chance for survival is very low, with conventional CPR going down to 2%. The other Swedish registry with almost 20,000 patients has shown also in patients with refractory fibrillation of their ventricles that 6, 7, or 8 defibrillations means that the chance for survival goes down below 10 to even 5% of chance, so very low chance of survival. In this setting, we have had a lot of non-randomized trials and series showing that with the CPR, there is really a chance for reasonable survival even after very prolonged cardiopulmonary resuscitation times. This is non-randomized data from Minneapolis, from the Demetrius Yiannopoulos group, showing nicely that after 60 minutes of CPR, still about 25% of patients may favorably survive. And this actually prolongs into such a long CPR times like 70 to 75 minutes. So what eCPR offers is actually a second chance to survive after the conventional CPR, represented here in this slide by the orange bars as being patients from a placebo arm of a randomized immunoderm study, showing that with conventional CPR, the chance to survive over 50 minutes of CPR is very low or zero. So eCPR definitely offers a chance for our patients with refractory cardiopulmonary resuscitation and unavoidable cardiac arrest. This is one of our patients showing a very bizarre ECG. This patient has been treated with prolonged CPR. This ECG changed into this one again, very bizarre ECG causing cardiac arrest, and the patient was rescued by eCPR. You see the lady the second day after such a prolonged 72 minutes CPR before she got an ECMO, still in ECMO, her groins and being quite well extubated into the full consciousness. This is what we have seen repeatedly. However, to replicate this in a randomized trial, it's not easy. This has been the first randomized trial published on eCPR, coming again from Minneapolis, the Demetrius Yiannopoulos group. And this study showing 30 patients randomized 15 to eCPR versus 15 to standard ACLS group after prolonged CPR on average of 60 minutes and only refractory shock, refractory ventricular fibrillation, out of hospital cardiac arrest, 43% survival in the eCPR group. So 6 of those 15 patients survived favorably over 6 months of follow-up. So this study has shown nicely that after 50 minutes of successful CPR, when the patient is admitted to hospital, if you don't offer eCPR, so if you stay with conventional CPR, the chance for survival is really negligible or zero. There's been only one patient who regained the return of spontaneous circulation, however, died within the first 3 months with a severe neurological deficit. So those patients should be offered eCPR. This is our center randomized trial published exactly actually a year ago, where we compared little different groups. So we actually compared a bundle of interventions, meaning intra-RS transport, extracorporeal cardiopulmonary resuscitation in case that the patient doesn't reach return of spontaneous circulation, and immediate invasive assessment and treatment. And we compared the 180 days favorable neurological outcome in those two groups. Our study, which lasted from 2013 to 2020, so has shown that within the 4,345 patients who have been resuscitated in Prague, Czech Republic during the study period, actually 6% of those patients have been randomized and have been the potential candidates for eCPR. Now, out of those 264 patients, we evaluated 124 and 132 patients, the respective invasive and standard arms. This is the main baseline characteristics because we started a study almost more than 10 years ago. We enrolled all rhythms, including ventricular fibrillation, which has been the majority of patients, 60%. We also included asystolic patients, around 20%, and pulseless ventricular activity, around 18% of patients. The study is important for implementation, because you have to realize that almost everybody in our study did receive bystander CPR, and the enrollment criteria was a witnessed cardiac arrest. Many of our patients, about 80%, received telephone-assisted CPR, which is also extremely important. And then pre-hospital logistics and pre-hospital early identification of cardiac arrest, early alert to emergency medical service, immediate bystander CPR, and as soon as possible, telephone-assisted CPR is a mainstay for eventual favorable outcome of those patients with a refractory cardiac arrest. And then the other times is pretty normal, as we see in European countries, so 8-9 minutes for the first crew to reach the scene, and then the physician was on the scene within 10 to 11 minutes, and the time for randomization on site was about 25 minutes, meaning that after those 25 minutes of CPR and cardiac arrest, our patients were still in cardiac arrest, still under active chest compressions, and they were randomized either to invasive or standard strategy arm. This is the procedures and how actually the group was defined. And the most important part is here, this is a time of CPR in the respective groups. And the time of CPR is defined as a time to death, time to return of spontaneous circulation, or ECLS. And it was 58 minutes in the invasive strategy arm, so almost 1 hour of CPR versus 46 minutes in the standard strategy arm. So this study is unique by the fact that we enrolled truly refractory cardiac arrest patients. So probably many of us normally would already stopped the eCPR, CPR efforts after such a prolonged cardiac arrest. And we still have put those patients on ECMO and have looked at the outcome after such a prolonged CPR. Despite the fact that the patients have been randomized during ongoing massage in the field, on admission to hospital, 27% of patients in the invasive strategy arm actually reached the ROSC during the transport or on admission, and 44 patients reached the ROSC on site, being provided with the standard cardiopulmonary resuscitation. So you see the number of patients who received the ROSC and who gained ROSC was higher in the standard strategy arm, which is kind of understandable, because the quality of CPR during the transport may be diminished. The other important part is a trained team on admission to hospital and a very high success rate of cumulation. You see we had a 96% cumulation success rate in our patients without ROSC, and the time of implantation was about 12 minutes since crossing the door to running ECLS. And this is important procedural characteristics of how we perform the eCPR. Taking this all into context and looking at the outcome, you can see that in the invasive strategy arm, 31.5% of our patients survived with good neurological outcome after 180 days versus 22% of survival, which is actually twice higher than the 10% of presumed survival we expected to have when we designed the study 12 years ago. So what happened here? Per definition, as an interpretation of a randomized controlled trial, we did not prove a statistically significant difference in the primary outcome. However, what we have shown is that after 58 minutes of CPR, using eCPR and such a sophisticated approach, we can still have 1/3 of patients surviving, including patients with asystoles and pulses electrical activities. And with conventional CPR, with all the change of the logistics and pre-hospital improved care, communication with the cardiac center, even in the standard strategy arm, the survival after 46 minutes of CPR can be truly reasonable. We have proven statistically significant difference in the neurologic outcome after 30 days, 31 versus 18%. And we did see a tendency to better cardiac recovery within 30 days, but again, this did not reach the statistical difference. Importantly, if you look to the subgroup analysis, and this is numbers from the shockable versus non-shockable arrhythms, in the invasive strategy arm, you can see that almost 50% of patients with initially shockable rhythm treated for refractory cardiac arrest, around 1 hour of CPR, survived. So almost half of those patients survived well with a good neurologic outcome. So this is the power of eCPR. The patients with shockable rhythms really do have a very good outcome. And recently, we performed the pooled arrest and out-of-hospital cardiac arrest trial analysis, which is right now under submission in the journal. And we looked at the survival with normal neurological outcome at 180 days in this pooled analysis of 2 randomized trials. And what you can see, and this is the primary outcome similar to the one we presented in the Prague trial. And you can see it was 32 versus 19.7%, so highly statistically significant difference in favor of an invasive approach, and the absolute difference is 13%, and this is for whole population in both trials, so the number needed to treat is 8 patients. And if you look at the subgroup of shock burdens, you can even see much better results, 47% versus 28%, which is almost 19% of absolute difference, again, highly statistically positive in favor of invasive arm. And here the number needed to treat is 5, so every 5th patient, if you treat actually, you save 1 life. So this is really important to say. So based on those 2 trials, we concluded that not just ECLS alone, but a comprehensive approach, including ECLS and meaning the ECPR, may have an impact on the logistic and the outcome. The Prague and our study had many positive findings, mainly very high percentage of bystander CPR, or very high survival in the standard strategy arm. Excellent survival in generally refractory cardiac arrest was about 30%, and there was a signal of benefit in the subgroups, mainly patients treated for more than 45 minutes, and almost 50% CPC1 and 2 survival in patients with a short rhythm. So this was very positive. However, about 6 weeks ago, there's been a Dutch study published in the New England Journal of Medicine. And this was a inception trial, again, randomizing patients with refractory cardiac arrest out of hospital to eCPR versus conventional CPR. And the results were very disappointing. There was no difference in both arms, only 20% survival in the eCPR group versus 16% survival in the conventional CPR group. And it was the same for 6-month survival with a favorable neurological outcome. So why did it happen? What happened in this trial? This trial was different to the previous 2 trials by the logistics. There was not a fully defined pre-hospital protocol, and you can see that the time of the start of cardiac arrest to start of cannulation was 58 minutes, which is not so bad in comparison to previous trials. However, median time from arrival to start of cannulation was 16 minutes, so 16 minutes delay before the cannulation was started, compared to previous trials where there was basically no delay and the cannulation was started immediately after admission. And even more importantly, start of arrest to start of ECLS flow, so the cannulation time and the time from arrest to establish ECLS was 74 minutes. So 15 minutes more than in the previous trial. So those 15 minutes are probably responsible for a decline in survival in this trial, because as one would understand, prolonging cardiac arrest, of course, the chance to survive really declines rapidly. So let me conclude that ECPR should become a standard of care for selected patients with refractory cardiac arrest. And based on those three randomized trials, still debate continues. And I would like to invite you to our ECPR Prague School, which is going to be in October 19 to 20 this year in Prague. And we will discuss very thoroughly with all investigators of those randomized trials and many other experts around the world, the ECPR and what is the best practices and how we should proceed with a ECPR and everything around prolonged cardiac arrest. Thank you very much for your invitation and attention.
ECPR. I have a few questions for you. So one is regarding the consent. When you are designing the protocol, it was already, how did you take consent for conventional ECPR versus invasive ECPR? Conventional CPR versus invasive CPR, that's the first question. The second question is regarding, is it a government funded trial or it is, I'm not aware of your hospital policy. And other question is regarding, you told that when you, at the starting of trial, you thought that you estimated the 10% of survival in the conventional CPR. So over 8 years or 10 years or so, the standard of care has increased. That is true for ECPR as well. So when you start the program, you do a lot of mistakes that you will improve over the time. So that the same logic can be applied for ECPR as well. And you told that NNT is of 8. So for every, to get a good outcome, 8 patient needs to be on ECPR. Did you look at the cost effectiveness regarding that? So usually, because for our country it may not be possible, and NNT of 8 is very high as if you look at the economy.
Okay, can you hear me well?
Yes.
Live? No? Oh, perfect. Thank you. So again, thank you for inviting me. I've listened to your session and thank you for your questions. So I will answer them very quickly. Yes, of course, you cannot take any consent during ongoing CPR. So our ethical committee approved the study without taking consent during the CPR. So the consent was, asked retrospectively in those patients. This is what is described in the protocol. That all the patients who regained consciousness were consented for data acquisition. If we couldn't get a contact with the patient, then we contacted the next of kin, and if we couldn't get in touch with anybody or the consent was refused, we didn't use the data. Therefore, if you look to the concern diagram of the study, you will see 8 patients who had to be excluded from the study because of this. The second question was how the study was funded. Actually, yes, we did get a Ministry of Health of our country grant for this study. At the beginning, this was a 5 years grant, but as you know, the study was ongoing for 7 years. So we were funded just by 5 years, and then we funded from our institutional resources. And basically, at this moment, ECPR is a state of art at our institution, so we just perform ECPR without any problems of funding. If you go to the DRG system, in the DRG system, the ECMO and of course ECPR is very well paid, so it's not a problem with the money. Concerning what was your last question?
It's about the improvement in the outcomes over a period of 7 years.
Yes. Yeah, great. Yes, of course. So this is not the first time in the history of medical devices and implementation of a new, very invasive strategies and sophisticated, logistically difficult procedures that by implementing such procedures, you also increase and improve the standard of care. So this is what happened in our trial. And when we designed the trial, we expected to have a survival of over 30% in the invasive arm, which became the truth. And then we expected 10% in the standard arm. But as you have seen, what happened is that it's simply improved. So There was not a difference between the arms, but the overall survival was very good. It was the aim.
I think if you look at your conclusion regarding based on the primary outcome, that is overall survival, there is no difference between these two groups, right?
Statistically, no. Yes, there is no difference, right?
Statistically, it is not statistically significant. But if you do you think that when you are for any study, if you are the conclusion you give the conclusion based on the primary objective what you are setting. But if you there's the second one, you are in the still submission phase. You told that the neurological outcome survival is much better with eCPR compared to the condition CPR. Do you think that the sample size with which you did the study, can you come to the conclusion because that was not your primary outcome? And the second thing is regarding the NNT. Do you think did you look at the cost estimate of these two?
Yes. Yes, of course. You have to read carefully what is written in the manuscript and what we actually compared. It was an intention to treat analysis. And if you read our manuscript, you have seen that we had an 8% crossover, which happens in ECMO studies and in cardiopulmonary resuscitation or cardiogenic shock studies. Inevitably, what happens is that in a certain amount of patients, and truly, it was in the standard arm, 11 patients who have been crossed over from the standard to invasive arm. And imagine that you have a patient who is 40 years old, that's refractory to ventricular fibrillation, is brought to the hospital after 8 or 9 defibrillation, still having signs of life. And you just continue conventional CPR and let the patient die if you know that you are able within 7 minutes to put the patient on ECMO and the patient is going to survive. So those are the patients we converted and we crossed over from the standard to invasive arm. And those are actually patients who improves virtually the survival in the standard arm because they were counted as intention to treat patients in the standard arm. However, they were treated by the invasive approach. So if you do per protocol analysis and do as treated analysis, this is much in favor of invasive strategy arm. And concerning your question to number needed to treat, we of course have to focus on shockable rhythms. Our study started and was designed 12 years ago. 12 years ago, nobody in the modern world was able to perform eCPR. It was a science fiction for all of us. And so we didn't know, so we enrolled all the rhythms. Today, we know very well that the shockable rhythms are appropriate rhythms for eCPR. And we actually stopped to provide eCPR for asystolic patients, and we provide very selectively for patients with PDAs or pulseless electrical activity, so mainly for pulmonary embolism patients. So, and if you look to the number needed to treat of 5, this is an extremely efficient procedure, much more efficient than any other that you can compare, like VATS, transplantation, ECMO for ARDS, and whatever else. And concerning cost effectivity, we do have data which are not published yet. If you have survivors, there is no difference in the cost of survivors in between invasive and standard arm patients. The cost is on behalf of those who do not survive and are being kept in a prolonged ICU care. So what I'm saying is that if you have a patient under eCPR, you have to properly provide a neuroprognostication, identify as soon as possible those patients who will not survive, who will have a poor neurologic outcome, and simply withdraw the care in those patients, and that's how you can save the costs.
That's excellent, because if you see numbers needed to treat for paracetamol to be effective, somewhere around 3 or 4. So you can see where we are talking about.
Yeah, and if you look to other interventions in cardiology, the number needed to treat, you've got absolute difference, like 2%. So this is 10 times less. But just to close, this is a very sophisticated and selective procedure for really a small group of patients. So importantly, this is for about 6 to 8% of all out-of-hospital cardiac arrest patients. This is not for everybody. This is important to say.
One quick question, sir. What is your call on a refractory cardiac arrest after CPR, after ECMO has been initiated? So you're not getting the heart back. So what is your call on those type of patients?
Yeah, this happens quite often that your heart doesn't go back, so you have to identify the cause and hope for having a acute coronary occlusion or something which you can fix fast and easily. If you don't have any, very straightforward cause of cardiac arrest, then this is a problem. And usually those patients who don't have a special cause, they recover very poorly. So patients with acute coronary syndromes, myocarditis, pulmonary embolism that you can treat, those are the patients who benefit the most. The other patients with terminal, cardiac failures, with metabolic problems, who are not able to contract anymore, those are patients, of course, who die. So therefore, still, whatever you do, 75% of your patients will going to die.
Is there any time frame you fix for that to come out of ECMO?
Yeah, this is a good question. If you take the whole population, I would say 25% of patients, they wean very quickly, they improve very quickly. You can win them of ECMO, extubate them, and they do good. Another 25%, maybe 30-40%, they do very badly. So you see they have a brain death, or they are really in a very fulminant multiple organ failures, and you disconnect them within the first 2 days probably and then die. And then you have the rest of 30-40% of patients who are kind of a borderline, and you have to stratify, neuroprognosticate, and wait. And our average time in ECMO was 5 days, so this is not so bad. And within those 5 days, you know whether the patient has a chance to recover or not. And actually, in the study, there was only 2 patients who needed VADs or transplantation. So that's a very low percentage of patients who need some kind of prolonged care in this regard.
Thank you. Thank you all the speakers, and we conclude this session. Thank you.
Thank you.